GP Insights, a HealthCert podcast. Practical advice for busy GPs on how to treat with confidence and grow their practice.
I'm here again with Jean Filanovsky from Canada, and some of you will have listened to our previous conversation, but some of you may not have met Jean. Jean, what we might do is ask you to give us a short version of where you're working. We talked about your background before, which was fascinating, but I think for those that haven't heard the prior conversation, just give me 2 minutes on where you're working at the moment, because it is interesting, I know, to our colleagues and listeners who are mainly here in Australia, but around the world, around the different models of care. Jean.
Yeah, so David, first off, I'm based in a community called Nanaimo, which is on Vancouver Island. Many of your listeners will be familiar with the city of Vancouver. Nanaimo is about 2 hours away by ferry. I arrived here 15 years ago to work at the regional hospital. I completed a residency in family medicine in 2001, but I never did any family practice. I went directly into further training in emergency medicine, spent my first career as an ER doc and a trauma team leader. And then in 2014, I started doing a day a month of skin biopsies and small excisions. My intent was just to cut back on shift work a bit, but the demand was huge. And over the course of the year, I kept getting asked to come in more often. I've always liked doing various procedures, so I enjoyed the work itself, but it's the patients who drew me in, as opposed to the high pressure, high anxiety environment of the ER. A skin cancer surgery is a fairly well-defined 15 or 20-minute interaction. There's time for a casual conversation. Yeah. And I found I really enjoyed getting to know my patients and hearing their stories. So now I'm doing full-time skin cancer medicine. Our clinic is called Skin Care West on Vancouver Island here. And we're a team of 8 physicians, 3 dermatologists, 4 family physicians who do a mix of dermatology and other things. And then we have 1 proceduralist who comes in.
Yeah. It's a really interesting model. And again, before we talk about Imiquimod and the clinical side, Jean, how common is this kind of model in Canada?
Uncommon.
Right.
I think similar to Australia, there's sort of there's quite a division between family practice and dermatology, and our clinic is structured on a very collegial, team-based environment, and there isn't a lot of that in Canada. It's starting. Yeah. You're seeing more and more of that happening. I think our clinic was one of the first. But it's slowly starting. I think there's a real recognized need in Canada. We're really underserviced in dermatology. There isn't enough specialty trained dermatologists to meet the need. And so family physicians are stepping up, doing additional training, gaining experience. So we're seeing that happening here.
Yeah. Do you think there'll be more of that, Jean, or do you think this is almost not a one-off, but you know what I mean?
No, I think it's going to be hopefully part of the future. And yeah. I really like our model to have specialty trained dermatologists working in the same location as family physicians in a sort of this team environment. We can consult with each other. We can share images. I think that's the ideal as a family physician going into dermatology. Yeah, it's really difficult to do that. You can get a lot of sort of the academic training, but it's hard to get some of that, the clinical experience and guidance from a fellowship trained dermatologist. I think in Australia, the model for family physicians where it's more focused on skin cancer medicine, or at least that's the way I understand it. It makes more sense. You've got mentors there who have years, decades of experience. Yeah. Whereas if you're going out and you're doing more of a general dermatology practice, that might be harder to find in Australia right now. Over here, we don't have either the dermatology mentorship or that deep experience in skin cancer medicine. Yeah. When I went into this, I worked as an ER doc and I left acute care medicine. It was pretty intimidating because I felt like I was forging my own sort of path, and there was no model. I was sort of let's see how this works out.
Yeah.
The training I did a master's at UQ, and I have to say that's the foundation for what I do today. The preceptors were fantastic, and just having that solid knowledge base was really helpful.
Right. Well, that's absolutely fascinating. Thank you for that. Let's flick into the clinical side of things, and the topic today is how you use Imiquimod in your patients. I think you're particularly keen to talk about the role with BCCs. Over to you, and maybe the way into this is talk a little bit about your approach to field treatments and field cancerization, maybe, and then topical treatments in general. Jean, your broad approach, and then focus in on Imiquimod for us.
Let's if you don't mind, let's start in a slightly different location. Let's talk about surgery for basal cell cancer, and then come at it that way, and then come at it from then into non-surgical.
Sure.
So we're pretty well set up here at our clinic. We've got a surgical suite in the clinic, and we've also got a pretty good group of plastic surgeons here in the community. So we can do in-clinic surgery. We can refer people out, and my background was I did trauma work and a lot of pretty interesting repairs in the emergency room. So coming into surgery for skin cancer medicine, I was fairly comfortable with that concept of, okay, it needs to be cut out, and here's the margins, etc.
Yeah.
But one of the issues that I started to come across more and more as your dermoscopy skills get better, you start to pick up smaller and smaller lesions.
Right.
And then you run into the problem of, well, how wide do I go around this lesion? Like, how much surgery is the right amount of surgery? And over here, one of our problems is the main guideline that we follow is the NCCN. Some folks in Australia will be familiar with it. Yeah. So the NCCN basically has two categories for basal cell cancer. It's got a high-risk group and it's got a low-risk group. It recommends 4 millimeter margins for a low-risk basal cell cancer, and anything on the face is a high-risk basal cell cancer, regardless of size.
Yeah.
So basically, if you're scanning with your scope and you find a 3 millimeter basal cell cancer on someone's face, the NCCN is telling you that you need to excise that, and their guidance is standard excision with wider surgical margins. So at least 4 millimeters, but they're pushing you to go even wider. So you're going to put in a margin that's like twice the width of this thing.
Yeah. And
so the extent of surgery for these low risk lesions, it seems excessive. And so going into it, the cure rates for surgery are highest, and certainly that's the gold standard. But you start to ask the question, what else is out there in terms of options?
Absolutely.
The other thing is patients, they put a pretty high value on cosmetic outcomes. Like if you look at the data, they put a high value on cure rates for sure, but that's more on the body. And so if you shift from the body to the face and you look at the data, they start to put a much higher value on cosmetic outcome on the face.
Yeah.
So looking at non-surgical options for BCC, there's a couple major trials that really inform it. So there's a group out of Holland that looked at treatment for superficial basal cell cancer.
Yep.
And I think the lead author is Eritz. It's published in the Lancet Oncology, the first of 3 publications from their group. So they looked at treatment of superficial BCC with 3 different options. So Imiquimod, 5-FU, and PDT. 600 patients. They published results at 1 year, 3 years, and 5. The first results were in Lancet Oncology 2013. And so at that point, 5-FU and Imiquimod were 80% each, and PDT was 70%. So it looked pretty comparable. You had two options, 5-FU, Imiquimod. Imiquimod is a little better. But then when they looked at it again at the 5-year mark, which is actually, it's published in the Journal of Investigations in Dermatology, and it's a different lead author, so that throws people off. It's Jensen, but it's the same study, same 600 patients. At that point, Imiquimod was around 80%, 5-FU was 70%, and PDT was 60%. So that's what really established Imiquimod as the alternative to surgery, at least for superficial basal cell cancer.
Right.
And then there's another set of studies that it's called the SIN study. So it's looking specifically at surgery versus Imiquimod specifically in nodular and superficial basal cell cancer. And that group is from the UK. The first study was published in Lancet Oncology again. And there the numbers were sort of low 80s for Imiquimod and high 90s for surgery. And when they published their 5-year results, it basically stayed the same. And their conclusion was that if you've got a cure after 1 year with Imiquimod, it seems to stay. You don't lose that. There isn't a trend for recurrence after about 1 year. And the other thing was there wasn't really a trend towards any kind of transformation. So it wasn't like they would come back and it would be an infiltrative variant or something of that kind. So even if it does recur, if you've treated a superficial basal cell cancer or a nodular basal cell cancer, it's going to come back as the same thing. Yep. You know, you could treat it non-surgically again afterwards.
Yeah. So I'm very much with you around giving due consideration to topical treatments. Let's put it that way, and not just instinctively going for the excision. Sort of related to this, where does curettage fit in your armamentarium?
Yeah, that's really an excellent question, and it's that's really the foundation, I think, of what I do. So, right. One of the studies that had a huge impact on me when I was in my training, there's the fellow named Barlow, who published in the JAD, Journal of the American Academy, in 2006, and it was a retrospective study just looking at curettage. You know, he said, listen, electrodesiccation and curettage is great. What if we just did curettage? And so it's retrospective, it's single center, single investigator, but really informative. And he looked at 5-year cure rates, and he had a 96% cure rate. Yeah. So just doing curettage alone is very effective. And then a number of people have looked at curettage plus Imiquimod. So there's a fellow by the last name of Wu who published, I think it was in the Australasian Journal in 2006. And he had, I think it was kind of mid-90s cure rate. And then there's a few others who have published afterwards and very, very similar numbers. So for me, the first step is a shave-based biopsy. Yeah. And then if it's a lesion that I think is amenable possibly to topical treatment or any lesion that I think will have a good cosmetic outcome if I just curette that lesion away. Yeah. Usually that's how I'll start. If it's a large superficial basal cell, I may not curette the whole thing. If I think I'm going to aim for the best possible cosmetic outcome, we might try to treat it more topically, but certainly if it's a small nodular basal cell, to get that highest possible cure rate, if we're going to go non-surgical, it'll start with curettage.
Yeah, that's really interesting. And I in my practice here on the Sunshine Coast in Australia, I see a lot of patients with very, very severe chronic sun damage on their skin. And it's very, very typical in my clinic to diagnose multiple tiny BCCs, IECs, little very early, well-differentiated squamous cells. And I'm finding that curettage, with or without cautery, is a very, very effective and popular treatment modality. Much more so than excision. Of course, I go to excision when it's appropriate and when necessary and so on. But with these very small lesions, which you have to treat, you can't ignore them just because they're small, you can get a very good pathology sample, of course, and if you select your lesions carefully, and as you become experienced in the technique, it's a very effective treatment. And I'm interested in your mention of the combination of curettage with imiquimod. Tell me a little bit more about that. Have you done much of that in your practice?
Yeah, I would. Well, first off, my practice is very similar to yours, even though we don't have the sort of sun exposure, here. Yeah. But it's a very selected practice because we're the referral center, and I end up getting all the people with the worst possible actinic damage. And my experience is exactly what you're experiencing. I do a tremendous amount of electrodesiccation and curettage on the body, for sure. Yeah. That's my go-to for superficial basal cell cancer. It's my go-to for smaller nodular basal cell cancers. A lot of we call it in situ squamous cell carcinoma here. So for sure. The one issue with EDC on the face that I find is the scarring, right? If you do those hypopigmented scars, especially on younger people, may not have the best cosmetic outcome. So there's a fine line there in terms of how much curettage can I do? Should I use electrodesiccation? Am I going to get hypopigmentation? Yeah. For me, the depth of the lesion is sort of a defining feature. When it comes to nodular, if I'm going to curette that lesion and leave an atrophic scar, it's not worth it, at least not from a cosmetic, perspective. But if it's a thin nodular basal cell that I can curette and get a good cosmetic result from, that's fantastic. Yeah. When it comes to combining curettage and imiquimod, I would say I do that on a routine basis. I always curette before any non-surgical treatment. I will curette first, and I do it at the time of biopsy. So I look at the lesion or lesions, and I'll do shave biopsies. And I'll make a decision at that time whether it is worth curetting this, or am I, is this going on to? Am I biopsying this for the plastic surgeon? Am I biopsying it for myself for later, or whatever it is? But if I'm thinking non-surgical treatment, I will curette it up front. Yeah. And then I will wait for results, and then I'll have either a call with the patient, or often I will bring them in at some point after, and we'll take a look at how things have healed. Yep. And that's when we make the decision about whether we go on to imiquimod or not. And the role that imiquimod plays for me, it's sort of like an insurance, essentially, against recurrence. I've already reduced their risk of recurrence just by doing curettage. I've looked at them to see what's the cosmetic outcome here. Like, is this something we just should go on to further surgery anyway because it doesn't look good or whatever it is? And so then I let them decide. I'll go over the numbers with them in terms of, here's the risk if we just observe. And that's the other thing. I mean, obviously, we should be talking about, what's the recurrence risk anyway, right? If it's just a little bit of margin BCC or... So that's the first thing, is just what's the option in terms of simple observation. And then we talk about imiquimod, and then we talk about PDT actually for BCC. That's something we're launching later this month. It's been it's been a long project of mine to get PDT launched for BCC, get all the protocols in place and all the staff training. We're actually launching that later this month. So those are kind of the two pillars of non-surgical treatment. And then we get into every patient. We always talk about surgery as well as the gold standard. And I go into the numbers. So they understand that, excision is high 90s, but if I go to a non-surgical treatment, I'm looking at somewhere between 70 and 90% cure rate. Yeah. No, that's fascinating. Look, I'm conscious of time. Let's pull this towards a close by asking what something we should touch on. How does all this play out in terms of cost for patients in your setting? Can you walk us through the key stuff there? Yeah, great question too. So we're fortunate that we can get imiquimod powder here, and we work with a compounding pharmacy that is able to compound it into like a generic cream base, basically. So that cuts the cost. The brand name Aldera is pretty expensive over here. I think it's around $500 right now, but the compounded version is around $200. So for a lot of patients, that cost is reasonable. If you're talking about better cosmetic outcome, don't need surgery, especially if you're getting into multi, if you've picked up a bunch of small basal cells, you've just done 3 lesions and we're looking at, 3 different sites that might need further surgery versus let's give it a go with topical treatment and see how it works out. That's a pretty reasonable cost.
It is. How does that compare with the cost of surgery, for example?
Yeah, well, we're in a public system here, so that surgery is still an enormous part of what we do because it's covered. Some people they don't want to pay anything out of pocket. They know they can go to the hospital and get it done. They can come to our clinic if we operate. It's covered. It's a government funded surgery. So that's one of the main reasons is still the main choice for most patients.
Right.
But for some patients who value a better cosmetic outcome, they want to avoid surgery if they can. Yep. Or the patients who are maybe they're burning out from so much surgery, and they want some alternative. After someone's operated on your nose twice, 3 times, you're running out of tissue and you're just tired of it all at that point.
I think that last one is a very good point, and I think it is an area that we as doctors sometimes forget and ignore or are not sensitive to. That for many of our patients who've had multiple excisions, they just get, as you say, they just get sick of it, and they're fed up with it, and they know these BCCs are not going to kill them, and that managing them rather than aggressively curing them, urgently. I think there's a lot to be said for that, particularly as patients get older and maybe a bit infirm and comorbidities and all the rest of it. So that's very interesting. Jean, I'm conscious of time. You've got to go to bed. I've got to go back to clinic and see patients. It's been wonderful to talk to you for these 2 podcasts, and something tells me there will be more to come. Thank you so much.
It's been a pleasure, David. Take care. Have a wonderful day.
Thank you.
Cheers.
Thanks for listening. If you like the podcast, please subscribe so you can get updates whenever we post more. And please share it with others. And for more info, please go to HealthCert.com.